be going on to our next speaker, Dr. Rushad Shroff, who's the medical director at Shroff Eye Center, Delhi. And he has another interesting situation, managing dark spots in Relex. So on to you, Rushad.
Thank you so much, ma'am. Thank you, and thank you for the invitation. I'm going to be moving from peel to a dreaded thing that we sometimes see in lenticular extraction, which is dark spots. And at the outset, I'd like to say there are no financial disclosures. So the causes of dark spots are inadequate laser delivery, which means that the femto laser is not firing the correct amount of energy into the stromal interface. Typically, it's because of debris or secretions on the surface or on the material on the patient interface. And this tends to happen more in cases where you're doing repeated docking. So I'm just going to show a couple of videos regarding cases where we've had issues and how to manage these dark spots. So here you can see there is this patient being docked under the ERITA system. You see that there are some kind of debris, but they are tending to go away as we are docking onto the cornea. So you see now it's docked, but as the laser is firing, what we notice here is a very, very large dark spot appearing, which is pretty much in the visual axis in the pupillary area. So the question in this was, why did this actually happen? And the answer was, when we applied the PI, you can see this. It's a very important thing to check the PI. You can see that secretion is right on the glass of the PI. And the surgeon didn't notice this, and that was why that happened. Now, the second case I'm just demonstrating is another case where we had a higher myopia, and then we had a little bit of dark spots appearing, and then how to handle the dissection if you do actually manage to go ahead. In that first case, we actually had aborted and we had done a PRK later because it was in the visual axis. So here you can see it seems like a reasonably regular dock. I showed a wiping of the surface to make sure that the debris are gone. Now you can see the laser is starting to fire. And again, we noticed some amount of dark spots, not to the same extent as they were in the first patient, but you can see that there are these two large patches where the laser seems to have created uncut areas. Now, in this kind of case, you're in a dilemma whether to actually go ahead or not. In this particular eye, we did because it wasn't exactly at the visual axis. It was just tending to touch the pupillary area on the inferior left. So typical technique where we go into the anterior plane first and then separate the posterior plane. This part was relatively okay, but I knew that it was going to be a little more challenging as we got further into the dissection. This is a slightly older video. What I've adapted to now is I normally use a forceps to stabilize the cornea, hold at the limbus when I'm doing this, because it just reduces your chance of causing any kind of perforation of the cap. What you can see is that definitely this dissection is a lot more challenging and difficult than it normally is. You start with the areas where it is actually dissected, and you try to separate those out with gentle strokes to the side. What we are noticing is that inferior area is quite adherent. So I switch from the sharper dissector to the spoon type. I do so you can dissect a little more easily with this when you have dark spots, and this is my preferred dissector when I do encounter these. And you can see gently we're trying to break all these adhesions as we go along. So gently with rocking movements from side to side, trying to ensure that we separate both the anterior and the posterior plane completely before attempting to actually remove this, because if you try and remove it without separation, there can be tags, and then that can cause a tear of the lenticule. So what we found was we did that. We went into the posterior plane. We're just reconfirming, just making sure that this is separated. There is an area of tag at around the 7 o'clock position, which we're not able to get rid of completely, which I'm going to then take with the forceps. Now, we did manage to get a grasp push towards the 6 o'clock position and then pull back. And then eventually we managed to extract the lenticule. In this, it's always important to make sure that the lenticule is complete. And that's what I'm doing here, just to ensure that it's a circular lenticule. And then we proceed. So the points to remember, according to me, in this is, if it involves the pupillary axis, just be careful about going ahead with the dissection, because the stromal damage can cause irregular astigmatism, which becomes difficult to treat later on. Dissect the cut areas first and then move towards the uncut areas in gentle swipes. I've started using a forceps to stabilize the globe. It helps a lot more. And if noticed early, there are talks about creating a deliberate suction loss and converting to a flap as well to rescue this kind of situation. So with that, thank you, and I would appreciate any comments and
Yeah. No, very valid points, Rushad, like ensuring that you don't unnecessarily get into a situation of repeated docks and undersurface being kept dry, and also ensuring meibomian secretions are washed off. All that is very critical. But let me ask Vardhaman. You are there, Vardhaman? Yeah.
Yes, ma'am.
So do
Yeah,
you have some kind of a threshold that if there are this much of dark spot, you would convert it to a flab, or you would be valiant enough to try it all? Because I think the only thing is going to be a suboptimal visual outcome the next day if there has been too much of dissection. So what are your
right,
thoughts?
ma'am. Yeah, ma'am. I think first, beautifully presented by Rushad. I think
Yeah.
he tried to go on to all the aspects. I think I agree that if the dark spot is in the visual axis, especially, and if it is a significant dark spot, then it may not be a good idea to proceed with the dissection. Maybe I think it may be a good idea to, depending on the let's say availability of the time frame, either to come back again and do mine some other time, or make it into a flap this time, or even do a surface ablation treatment. But if it is in the visual axis, if it's a significant dark spot, definitely I think I will avoid to do a dissection. Nowadays, fortunately, it has become extremely rare. Actually, I think if I really see in last probably few years, I've not had any patient to have this kind of dark spot. I think the most important thing will be to be very, very careful about the interface, that there is absolutely no debris. Fortunately, in Visumax, as against in I think Elytra, we have excellent visualization when the docking is done. And therefore, I think even if there is a small speck of a very small debris, we definitely come to know about it. And then definitely it is not a good idea to proceed. It is better to clean the docking interface and then proceed with the application of the laser itself. But yeah, I think I will agree that if it is in the visual axis, avoid it. If it is in the periphery, it's very small. Definitely you can dissect it. It is quite possible. Yeah, but it has now become quite uncommon actually with the current energy optimization and being very careful about the interface.
While you're on top of these dark spots, is there a consensus that which kind of sometimes we have an unexpected difficult dissection? Either in which kind of corneas do you think, Rishi, you think you might expect that difficult dissection? That dark spots have become very infrequent because we're all very particular about the undersurface being dry and no meibomian secretion and all that. Do you feel there's any moment in any particular cornea when you feel that the dissection is, you sort of expect it to be a little tougher?
I think it depends on the OBL. If you get a nice OBL pattern, I don't think there are specific corneas in which you get easier dissection or difficult dissection. You can correct me if I'm wrong. It's just that some uh, corneas you get a better OBL and some you
Yeah.
don't get a better OBL. I think it's just about that. So your energy setting, optimization, etc., is I think more important, and how well you dock. I think that is the key.
No, I think
Ma'am, can I?
the
Yes.
points made by Rishi is absolutely relevant. But just by the way, maybe a stronger cornea, like Pooja mentioned during a presentation, even for the peel technique. If
Thicker cornea.
you see that the curve a thicker cornea, stronger, where the curve shows a higher tensile strength, maybe there could be a little more resistance. Very nice presentation, Rushad. I mean, I just want a clarification. You said absolutely agreed, and Vardhaman also said that if there's such a large dark spot in the center, better not to proceed with the dissection. But instead of postponing it to a PRK later, could you have used the circle software and convert it to a flap and complete the treatment right away?
in Elita, there's no circle software, there's no rescue
right,
mechanism,
right.
so I can't
Right.
convert to that.
Actually,
So
I was
one other
surprised you
point
got
that
such a good, smooth dissection at the end with such a big dark spot.
Yeah. Actually, but
Can
the,
I make a comment, ma'am?
Can
yes,
I
yes, Natasha.
So Rushad, wonderful presentation. I think we've all had this in our earlier, cases that we've done. I started keeping a disposable dissector. So if I'm having a dark spot which is less than 2 mm, I don't even try to manipulate with anything else. So the areas where it is the OBL is very beautiful, and I don't get a black spot. In that area, I dissected with the normal smile dissector that we conventionally use. But in the area where I have a dark spot, just in that specific area, I put in a dissector and sort of cut it out with the manual dissection.
Yeah, that's
Just
why I
something
switched to the spoon also. It makes it kind of like that. That was one reason of doing that. The second thing, sir, to your point was that at least in Elita, I've noticed that I have different energy settings for higher myopes versus lower myopes, and I keep a slightly higher posterior value of the energy, and that tends to help a bit more with the separation. If you keep lower energies, which we are trying to do for our, say, refractive errors of 3 and below, I have a different setting for that, different setting for 3 to 6, and then above 6, I have a different setting just to kind of take care of these issues as much as possible. And the first case, of course, it was just about looking at the PI. I mean, it was a new PI, so no one bothered to check it. And then suddenly, when you go back and see the video, you see that huge secretion on the PI. It wasn't on the patient, actually.
If you've had in an extreme situation, which might not have happened to any of us, if you have had a tough dissection and you've not been able to separate the lenticule, but the lenticule, you guess, might be a little folded too, would you actually ever do a surface ablation on the same sitting, or would you abort it and take it up later? Expert panel or anybody on the comment on that?
Once you dissected the lenticule, and especially if it separated the posterior plane also, it may get a little irregularly placed as well. So that itself will cause some irregular astigmatism, I feel. And it
Yes,
may alter the refraction. So once you've initiated a dissection,
that's what
uh, I think it's better to just try and get it out and deal. Maybe a circle software would be a better option, if at all.
yeah, yes. Thank you very much, Rushad. Wonderful.
Just a
If I
quick
can
point
make
wanted
a
to add
small
on
comment.
this.
Yes, Shreyas.
Yeah, sorry.
Yeah.
No, wonderful video, Rushad. And this is a problem over the years with Smile Silk. I've encountered it many times. And unfortunately, with that many number of cases, I felt that alteration in the dissection technique, which helped me, is that traditionally we do the anterior dissection first and then do the posterior. But in these cases where there's a dark spot, and generally if you see, the deeper the layer, the less the energy has gone in. And usually, even though the dark spot is in the anterior surface, the anterior cap cut is a little easier to do than the posterior lenticule cut. So generally in these cases, after delineating the lenticule, I complete the posterior first because you want some counter traction. When the anterior is still attached, you are able to use a little excessive force, but still the lenticule doesn't fold or doesn't bunch up. If it's right in the center, it's easier. I mean, in a way, at least to complete the dissection, because you can use a little bit of force and the lenticule won't fold. But if it's towards one side, then when you go to that side, it folds up from the opposite direction because your counter traction is lost, and it becomes difficult to complete the dissection on that side. So a useful thing which I found for myself is that I usually do the posterior first and then come to the anterior and complete it. And usually you're able to remove the lenticule in toto and even in these situations.
That's a nice point, Shreyas. And actually, I kept switching between anterior and posterior in this particular eye. I've edited it, but I'd done that anterior part, then I went posterior, I did more of it, then I came back anterior. So that actually makes sense. And now that I think about what you're saying, that's pretty much intuitively what you end up doing anyway.
Yeah, that's true. And quickly, one addition to that, generally, while it is easier to dissect the other areas first, I would still not dissect the area where the OBL is clear. Again, just to have that lenticule traction there. So I will go around the area of dark spot, complete the dark spot area, and then do the areas where the OBL delivery is very good. So laser delivery has been good. So that also helps in easier dissection.
Yeah, makes sense. And with these valuable discussions,